so excited to see so many of you here, despite the fact that the word statistical is in the title of this talk. I'm really glad you came. It's an honor for me to be here, and thank you for that introduction, Mike. Also an honor to be part of this department and sort of a pioneer biostatistician among clinicians and basic scientists, so it's a unique role, a fun role for me. I get to work with really brilliant people and answer really exciting scientific questions. I also get to be a little bit mysterious in having a role that other people don't have, and I like that. I like that being misunderstood and sort of distrusted, and it gives me a little bit of power, which I would never abuse. But I like it. I have a great job. I mostly work on herpes research, so one of the data example that's going to carry us through this whole talk is about HSV. But you know, the title looks a little bit long. Really, I'm going to spend some time introducing you guys to ROC curves, what they're for, and then I'm going to try to tailor this talk to the level that I think will be beneficial to you. I'm not going to teach you how to run these so much as to how to think about some of the issues that might be relevant when developing assays, which is something that you're all doing. So this topic was actually recommended by Mike Ashton and John Tate as something that hopefully will be interesting and relevant to you. Can I just ask how many people have heard of ROC curves? Yeah, okay. How many people have performed an ROC curve? Excellent, okay. For those of you, fall asleep for the first 6 slides and then come back on. You'll be good. I'm just going to introduce these in a general way first so we're all on the same page. This is an example of an ROC curve. And the purpose of these, which I'll write out as well, but I'll describe now, is that we are comparing 2 diagnostic tools. And the ROC curve gives us all possible assessments of the agreement between them. The 2 diagnostic tools are some gold standard binary measure, which gives us disease status, and then some continuous marker, which is either less expensive or less invasive or something that's more easily attainable. And it has a continuous value. So you might be using CA-125 as the marker, and breast cancer, maybe a biopsy to assess breast cancer as a binary gold standard outcome. And so the y-axis, I'm going to point to the y-axis here is the probability of testing positive via, say, CA-125, the probability of being above some cutoff via CA-125 if you, in fact, do have breast cancer. That's called the true positive fraction. And here, along the x-axis, is the false positive fraction, the probability of being positive by the marker if, in fact, you do not have cancer. And the idea is we want to be up in this corner. We want to have a high true positive fraction and a low false positive fraction. I'm going to try to remember to stick to that terminology. As statisticians, we call it sensitivity and specificity, but that means something else for you guys. So I'm going to try to keep it to that. And so there are 4 examples of ROC curves on there, and I'm going to show you what they look like if you were to start from data. And I should say my preference in these kinds of talks is if you have a question, please give the question as we're going rather than save it till the end, because I'd like to keep everybody along with me. So here are the 2 measures that we're comparing. Some marker, A, and let's just say it was CA-125, which probably is not on this scale, but imagine it was. The marker is here, and you have the distribution of the marker in a population that does have breast cancer and in a population that's healthy here in the solid line. And what we're doing is trying to assess how accurately does that marker value predict the true disease status. So the ROC curve, in fact, gives us all possible cutoffs that we could choose, a cutoff being some vertical line we would draw, by which anything above that marker value would be classified as cancerous and anything below it would be classified as not cancer. So hypothetical, this is just a made-up curve. Imagine that our cutoff of 7.5 was chosen such that anybody above that value was classified as having cancer and below it was classified as healthy. How well would this perform? Well, if you just look at the curves and sort of ballpark by eyeball the area under the curve, about 60% of people who have cancer fall to the right of that line. So this would be a true positive fraction of 60% if we let that be a cutoff. And if we eyeballed the area under the solid line here, I would say about 30% of healthy people would also fall above that cutoff. So that's just one cutoff we could choose. We could choose one that's higher in order to reduce the false positive fraction. There we go. I think this reduces the false positive fraction to about 5% of healthy people, but it also reduces the proportion of people who have cancer that we're actually classifying as having cancer. So it reduces the true positive fraction to about 40%, which is about the success rate I'm having with the pointer. Okay. And to go back, so what that looks like, it probably looks about like this curve B, where I just put a couple of the points on the curve, and that's what's being plotted, is the predictive accuracy of every possible cutoff that you could choose for marker A. So the orange cutoff is the one that was a little bit higher, right, where we were able to reduce the false positive fraction. And the blue cutoff was the lower one. And it's usually ends up being a trade-off between these two, right? We have to give up one to get the other. Just to finish illustrating the point about the difference between curve B and these other curves, what might a useless curve have come from? What kind of data might a useless curve have come from? And here's what I'm calling useless marker instead of marker A. The distributions for that marker for healthy and cancerous overlap almost exactly. And what that means is no matter what cutoff you pick, the proportion of people who have cancer who fall above that cutoff probably about the same as the people who don't have cancer who fall above that cutoff. And that's why the useless marker draws a straight line exactly between the true positive rate and the false positive rate. They're almost exactly the same. And then an example of how you might get a perfect ROC curve might look like this. Again, just hypothetical distributions. Say the marker separates those who have cancer and those who are healthy so perfectly into two groups that you can draw a line right down the middle and separate them. That would give you this nice line all the way up into the left corner where you have a true positive fraction of 1 or true positive rate of 100% and a false positive rate of 0%. That almost never happens, but we aim to be up in this top left corner. So if you got that far, then you're going to understand all the rest of the talk. But there's going to be another a real data example to illustrate one more time the RLC curve before we get too heavy into this. Here's the outline. There are 4 sort of special extensions to RLC curves after the review. The 4th one is really just sort of an FYI. We won't have time to talk about that. But if you are developing laboratory assays for which there is no gold standard known, there are in fact some methods out there that compare assays and don't require the gold standard to be perfectly sensitive or perfectly specific in order for you to get some information out of your assay. So it's just something to think about. What we will have time to talk about is how to incorporate financial cost, which is not the most cutting edge advance that I'm going to show you, but I think it's interesting and potentially applicable. We'll talk about how to incorporate additional predictors into an ROC curve, and then how to make comparisons between ROC curves if you have multiple tests and you want to choose between them or perhaps combine them. And then one important topic we'll get to is how to report your findings, because I not only want you to be able to say, here's this great test that I've developed, I also want you to be able to convince other people that this is a good test, and I have some advice on what's a good way to present those findings. And then more things that we won't cover in great detail. So the common word on this list of resources that constitute the materials in this talk is Pepe, and you may know Margaret Sullivan Pepe. She is faculty in biostatistics. This is really her area, and she is the one who's pretty much doing all this methods development in the area, so she is the local expert. If her name isn't on it, it's one of her fellows, one of her students. So she's definitely someone you can consult with, but I'm also able to help out some of these issues. And here I'm just writing out what I've already said in words, but to get it in print, what are RLC curves doing? They're allowing us to compare two measures of disease, where you have a binary gold standard and you have a continuous marker. And the continuous marker might be preferable because it's, like I said, cheaper, more easily accessible, less invasive. And the comparison between them might be because you want to assess disease status at the current moment, or because you want to assess some predictor of disease status later on. So it could be used for either diagnosis or prognosis. But the ROC curve is going to graph out for you all possible cutoffs of that marker that might be predictive of the gold standard. This is it for terminology. If you can remember TPF and FPF, you'll follow all the rest of the slides. This is the true positive fraction, the proportion of people who are diseased who are correctly classified by the marker. False positive fraction is the proportion of people who are healthy, who are classified incorrectly by the marker. And the ROC curve is going to plot one versus the other every time. These other two measures are on here because we're going to talk eventually about presenting results. And in fact, true positive fraction and false positive fraction are not necessarily the most informative tools that you would use to present the accuracy of a test. Positive predictive value and negative predictive value potentially are more clinically meaningful because they tell you, as you're handing a result to a patient, here's how likely I think that this result is true, right? I'm giving you a positive test result, and here's the probability that we think you're really diseased, or here's a negative test result, here's the probability that I think it's accurate. So they're a little bit more complicated to compute, and they, in addition to requiring these true positive fraction and false positive fraction, they also require an estimate of the prevalence. Okay, real data. Ro tomorrow is, I think, in Hawaii right now. Otherwise, she would love to be here and see her data up on the screen. But this is something that she's been working on, assessing the how well Focus ELISA performs relative to her Western blot gold standard in detecting HSV2 seropositivity. The reason we're looking at Focus ELISA again is because this data comes from Kampala, and there was concern there was some maybe strains that were a little bit different. Maybe ELISA was performing differently over there, even though both these tests have been in existence a long time. So we have an assessment of a continuous marker, which is the Focus ELISA value, versus the Western blot gold standard, which is a yes or no answer. You can see the distribution in the pink bars of the Focus result among people who are HSV2 seropositive by the gold standard, and in the black bars, the Focus ELISA among people who are HSV2 seronegative by Western blot. The reason these are bumpy, right, is this is real data now, no more made-up curves that we just draw. But these are, in fact, just frequency histograms. And again, let's draw some cutoffs and see how they look. If we picked a cutoff way over here on the left, you would get a great true positive rate. Most everybody in the pink bars falls to the right of that blue line, and they would be classified as positive based on ELISA. But only 40% of people who are truly seronegative are below that point, so we actually have a false positive rate of 60%, which is pretty substantial. Pick another cutoff, somewhere between 2 and 3, and we can get a much lower false positive rate. There's only about 3% of these little black bars that are above that point, right around here. And we're still classifying. We still have 90% of the truly seropositive people above that line, so that's not bad. Although we're trading true positive rate. So here's the full curve, and again I highlighted the 2 points that were on the previous figure. This is the higher cutoff, right? That would give you a lower false positive rate. But the curve is going to draw every possible cutoff. It's just going to pick a point all the way across that previous plot and say how well would this point do in estimating the true Western blot's status. And that was it. That was it for the introduction. As far as ROC curves go, if you've got the concept down, we're moving on to extensions. Does anybody want to ask a question at this point right now? Let me just go back one slide and say, yeah, that the next extension is about how to decide between these points. And you may, for a lot of tests, you may be able to look at this curve and say, I know exactly which cutoff I want to choose, and it's based on clinical interpretation, or it's based on, in herpes we talk a lot about psychological impact to the participant of false positives. So you may look at this curve and say, okay, I can accept a false positive rate not greater than 3%. And you may be committed to this far upper left corner here, and you may already have chosen your cutoff. If not, here's a way of choosing a cutoff, which is incorporating cost. And in a hospital where we're running a lot of tests and patient cost is a consideration, this may be a useful tool. So here's what you need in order to determine an optimal cutoff based on cost. You need the cost of these 3 things. You need to know what the cost of treatment in disease subjects is. You need to know what it costs to false diagnose somebody based on the screen. Are you going to treat them without additional workup, or are you going to continue to test? and you need to know the cost of missing a positive at the time of screening. So is that person going to continue to get diseased? Is their disease going to continue to worsen? And will later treatment be more expensive? That needs to be taken into account. And these costs could drive your decision. So if you have, if additional workup is really inexpensive, like in HSV, it's pretty reasonable to treat people, over-treat with acyclovir. You may be willing to accept a high false positive rate. Or if this delayed treatment is really expensive, that may be the driving factor. And I'll just show you what the calculation is. This is the closest we're going to get to an equation on this talk. So if you're okay with that, you're all good. The total cost of any diagnostic test can be computed, and this is going to be sort of on average over people, right, as a cost of each type of result. The true negative results shouldn't have any additional costs, right? They won't be treated. But we're going to treat the true positives, and the false positives and false negatives will require additional expenditure. We actually know from the ROC curve what this number of true positives, number of false positives, number of false negatives. We know those numbers. Comes right off the curve, right? We have a false positive rate, true positive rate, and we have a prevalence. So we know exactly how many people we expect to fall into these different categories. So we can just add this up if we have the prevalence and calculate the cost. And my suggestion is let's, as a simple tool, let's just graph the total cost over all possible cutoffs. And let me take you through a data example then. Still sticking with this HSV data, and these are hypothetical costs. But imagine that Western blot confirmation costs $80. And then you have to do that in both the false positives and the true positives. But in addition, you're going to treat the true positives, and maybe acyclovir costs $40 more to apply. But maybe the driving cost is this delayed treatment. Well, why would delayed treatment be expensive? There's some studies going on in Africa right now that are testing a hypothesis that perhaps in people who are dually infected with HIV and HSV, that acyclovir treatment might actually slow disease progression in HIV-positive people and delay the onset of antiretrovirals. So if you had HIV-positive people and you were able to detect them early, you might be able to allay the cost of antiretrovirals later. So delayed detection could cost you more in antiretrovirals. It's hypothetical, but it might illustrate the point. So we're going back now just to show you the ROC curve one more time, where we're trying to choose an optimal cutoff, and now we've made up these costs for each type of error we might have. Here's what the cost curve looks like based on those three costs that I put forth as examples. And again, I said, in addition to the false true positive rate and false positive rate, you need a prevalence. So we're just guessing here what the prevalence might be. If we have the higher prevalence, 80% HSV2 seropositivity, the minimal cost is about, the minimal cost occurs if you choose a cutoff of 1.5 for focus ELISA, just based on the graph, and it'll cost you about $105 on average to run a screen where you start treating people above that cutoff. If the prevalence is a bit lower, in fact, the optimal cutoff is higher, right? And the reason is because the driving cost was the missing those positives. The driving cost was the false negatives. And when the prevalence goes down, there are fewer true positives, so fewer false negatives. But this is just one way to go about incorporating an additional measure that can help you choose a cutoff, an optimal cutoff. So extension 2 for ROC curves is, let's start adding additional variables. Now, we no longer just have a marker and a disease status, but we also have other factors that we either know or suspect to be clinically meaningful that might help to predict either disease status or the performance of the marker. So you may just have demographics that you know are related to the outcome, and you may want to include those. And there are two reasons why you would want to include those. One is that the distributions of the marker might just be different in those populations. And if you don't take into account what you know about that covariate, you might have a confounding effect. And the second reason is, in fact, the accuracy of the marker might be different by population, which is a slightly different issue, and we call that interaction. And I'm going to show you graphical examples that will illustrate those points. So now we used to have 2 variables, and now we just have 3. We still have a continuous marker, which now has this range, -2 to 4, something like that. And we still have disease status. This is not diseased and diseased for some hypothetical binary gold standard. But now, in addition, we have gender. So we just plot the distribution of the marker by disease status for each gender and compare. And what it looks like is, for females, everything's just shifted over to the right. Everything's just higher. They're just higher by this marker, this hypothetical. Such that if you were to ignore gender and pool the marker values by disease and non-disease status, they'd be actually a little bit flattened, a little bit more spread out relative to what they are up here. And the consequence when you build an ROC curve is if you ignore what you know about the covariates, which is this pooled ROC here, you get a gray curve that's actually down and to the right from where it might be if you were to take gender into account. This black curve actually gives the ROC curve for either males or females separately. So ignoring gender can tell you, that your marker is not performing very well, when in fact including gender would give you increased performance in your marker. So there's reason 1 to include covariates when they're relevant. Here's reason 2. Now, in fact, we don't have distributions that look identical but slightly shifted. We have distributions that distinguish disease from non-diseased in different ways based on the covariate. So for males here, the diseased are quite a bit above the non-diseased for the marker, but for females, the distinction is not as great. The marker actually just doesn't predict disease status as well in females. And so what you get if you plot the covariate-specific ROC curves is that females are much lower, farther to the right. This marker is not as well able to distinguish. That if you left a pooled number in there, you get something sort of in the middle if you just pooled your data and ignored gender. But this is, is possibly even more important, right? If you were to, take it to the extreme and say we've got a population in which this marker very well distinguishes disease from not diseased, and another subset of the population where it doesn't work at all, doesn't predict at all. Then you go and try to implement this tool without taking that population indicator into account. You really, it's detrimental to assume that it's working everywhere. So this is the other reason why you would want to look into covariates, and this is the interaction concept. So how do you go about including covariates for an ROC curve? There are actually lots of choices. And if this was the Department of Biostatistics, your eyes would have skipped down to this word semi-parametric methods, which is in yellow, and you'd be salivating. You'd be so excited that there are more equations coming. But this is not the Department of Biostatistics. Really, probably what you'd rather see is big color glossies of genital lesions, which I'm also not going to give you. Instead, I'm just going to talk about the concept that's illustrated by these possible methods. I've put a little bit statistical ease up here in this first one too, but all this means is draw a line and count up what's to the right of it and count up what's to the left of it, right? If we have a discrete covariate, you just want to know, does it help you predict the performance of the marker? Just draw separate ROC curves and count up what's a good cutoff. But then we have these other regression tools. And this is really all I'm going to say about it. Linear and logistic regression are great. They are accessible. They make assumptions about the distributions of your variables. So they're useful. Semi-parametric methods, which is what Margaret is really at the forefront of developing, will get you around those assumptions and provide you something that is possibly more accurate. When what you're looking for in both these cases is just, are these curves different? We have this nice summary statistic, which is called area under the curve, and I'm going to calculate that for you a couple times to show how different they are. Or if you're performing a regression, then you're just looking at the significance of the covariates that are included in your regression. Do I need gender in this model? Do I need an interaction of gender by disease status in this model? Okay, so let's implement this looking for covariates in the data set example that we've been using, which is ELISA versus Western blot. So I put in HIV status. We actually have a few subjects who are HIV positive, and that's this pink curve You can see it's a little bit of a rougher curve because there are fewer data points that constitute it. But it does appear to be a little bit higher. So what that means is not that the focus value, in fact, is higher among HIV positives. It actually means that there's potential for the focus ELISA to be better able to predict Western blot status. It might be a little bit more accurate among HIV positives. But eyeball might not be the best test we want to use, so let's try some other measures. And what I wanted to show you is we can calculate this thing called area under the curve. And that is shown in these shaded regions. The pink area under the curve is just the distance between the line and the bottom. And you may want to do that over just a small range because, like I said before, you may be unwilling to accept false positive rates above a certain cutoff. But what does that value give us? Why would we do that? What is this area under the curve? It's a sort of a neat probability. It tells you really your ability to distinguish disease from non-disease. It tells you the probability that a person who is truly HSV2 seropositive will have a marker value or a focus ELISA that's higher than someone who's truly not diseased, HSV2 seronegative. And if you go back, these are some pretty impressive probabilities, actually. 99% of the time, an HIV positive person, their focus value among HSV2 seropositives will be above those who are HSV2 seronegative. 97% of the time, it's true in HIV negatives as well. But we can test whether we need to consider HIV status also using logistic regression. And so here's a p-value, first p-value, to tell you whether this HIV status is actually predictive of the performance of ELISA. And p equals 0.19 is above 0.05. Everybody knows that's sort of the cutoff. So it seems like these curves are not different. And maybe the test is performing equally well in HIV positives and HIV negatives. And just another comment about these analyses. You have actually a lot of choices for outcomes. You can, in linear regression, you would use the marker. Logistic regression, you'd use the disease status. This is an area that Margaret's developing where the outcome of the regression is actually the true positive rate. And this requires some fancy software, but it actually gets more directly at what we want to know, which is this area under the curve. How well are we able to distinguish disease from non-diseased? So I'm just throwing it out there as a comment, and I'm not going to show you what those equations look like. And we're already on to extension 3. So ways to take into account covariates. And now, what if you have multiple markers, and how do you go about comparing those markers one to another? And in addition to cost consideration, we can use statistical tests. You may have, there may be a standard of care assay out there like CA-125 in breast cancer, and you may have something new that you're developing and you want to know, is it better? Can it replace CA-125? Do I need them both? Should I use it in addition? So here are some ways to go about that. And I'm just going to back up for a minute and imagine that instead of all these continuous markers, we have just yes or no markers for the moment and a yes or no gold standard, and we can make nice little 2x2 tables. In order just to introduce this measure, which is change in positive predictive value, as a tool to assess how well your new marker might be working, we could look at odds ratios. But this is a really clinically meaningful way to summarize the performance of a marker compared to something that was available before. So the change in positive predictive value, if you have a new binary marker, would be probability of being diseased if you've got now 2 positive readings on your markers over what used to be available. Probability of being diseased on the standard tool. And this is just a neat way to present the clinical usefulness of a new marker. But if you were in the continuous case, we have more decisions to make, right? We actually need to figure out what this cutoff is as well in order to calculate the change in positive predictive value. But this is more the case that we tend to find ourselves in, is working with Chris Posavad and looking at proteins that might be used to identify seropositive people, calculating immunogenicity with flow cytometry. We've got 17 different proteins we can consider. How many of them are actually useful? And we can look at different combinations of those in improving positive predictive value. But let's go back to our data example of the Kampala Sierra. So in addition to this focus ELISA, which is the standard and the least expensive, we have some additional tools, something called Kalon test and BioKit. They're a little bit more expensive, but they might be a little bit more accurate. So the question is, is the improvement substantial enough where we want to implement these tests? Is it going to be worth the cost? So we can look at ROC curves for several tests at once. And I think that's what we have. Good. Now, this is different from where we were splitting before by HIV status. Here, actually, every subject is in both curves. Every subject had all three tests performed. They had the Western blot, and they had the focus ELISA, and they had Kalon performed. And the question is one better than the other? Well, focus was already doing pretty well, if we remember, in the full population, but Kalon seems to be a little bit above that. So how much do we care? So here's some tests. We have non-parametric tests, we have regression tests, and we're getting some significant p-values, in fact. Interestingly, it's the same p-value, which never happens. I thought that was fun. But here we're comparing the area under the curve for focus versus Kalon. What that means is one able to distinguish Western blot positive from Western blot negative better than the other? And the statistical test says yes. If we do logistic regression, we get this incredibly high odds ratio for Western blot positivity if Kalon positive, 23.8, which is much higher than the odds ratio for focus, which is only 4.8. And this is actually a p-value for an interaction term, 0.016, saying that Kalon performs better than focus at determining Western blot. So it seems to be the answer is yes, that we have a difference between these two tests. This is my favorite slide in the whole talk because I never get to talk about this. People always tell me about, well, Amalia, you're the statistician, you're just interested in the p-value, but you need to think about clinical significance. Well, I remember clinical significance. So I'm pointing this out. I get to point this out. Here we have these really high significant p-values, and we have these great odds ratios on the left showing that Kalon is much better. But we need to frame this in a context of by how much, so clinical significance. And if you compare the areas under the ROC curves, we're talking about a difference of less than 1%. So our ability to accurately detect HSV2 seropositivity by the gold standard is not dramatically improved. If we put it on the scale of change in positive predictive value, which we can just pick a cutoff and say, what's the positive predictive value if we let's say the false positive rate is going to be 5%. Here's our cutoff. Let's say prevalence is 80%. The difference between the positive predictive values is now 0.1% between these two tests. So impressive statistical power to detect a difference. Clinically, I'm not sure I'm real excited. So here it becomes a matter of, what's it worth to pay for the more expensive test of Kalon. All right. So we've been talking about this pretty much through the whole presentation here, how you want to present your findings. And what I'm showing you from the previous slide is we had an odds ratio of 23, and we had a difference in positive predictive value of 0.1%. There's something going on here. There's something different between these choices, and we need to think about what's more clinically meaningful and how we want to present these findings. So odds ratio, we're real familiar with that. We see that in most studies, right? This change in positive predictive value we've been talking about, it requires that we pick a particular cutoff and say how much better does the test perform at this point. Change in area under the curve is a great summary measure of the whole ROC curve, and is coming to be the preferred way of presenting accuracy findings in these kinds of studies. So we need to think about the trade-offs for these. And I've just got a couple slides to show you other cases where we can compare directly an odds ratio and an ROC curve or a positive predictive value. These are, I should point out, I put all the papers that that are being referenced in this talk at the beginning. I gave a list, but also these figures come from Margaret Pepe's papers. So this is a graph showing just hypothetical ROC curves at given odds ratio values. Here's an odds ratio of 3.0, and that's, if you see that in an association paper, something with disease status has a 3-fold increased risk, generally you'd be impressed, right? Odds ratio of 3 sounds big. What it means for a marker is it might have, say, a true positive fraction of about 60% and a false positive fraction of about 30%. Really not all that impressive when you get to diagnostics. Remember, the focus results have been way up here in this top left corner. The odds ratio is in the hundreds when you get up to that top left corner. So we need to be careful to be not too impressed by odds ratios. Another figure that shows the same thing at the level of distributions of the marker by disease status. Here's that odds ratio of 3 again, right? These curves almost overlap, where the diseased and non-diseased populations are really hard to separate. Once they start to show some substantial separation, the odds ratio is just incredible. So just a reminder to not use that scale. Another reason why to avoid odds ratios when assessing accuracy of a diagnostic tool. These two graphs, if you just eyeball them, this one's all purple, I guess is this color. Most everyone's being classified as negative by the marker, whether they're diseased or not diseased. And this one, everyone's being classified as purple or positive by the marker, whether they're diseased or not diseased. They both have this incredible odds ratio of 2.25, but they're actually performing pretty crummy. And the point is that you're unable to distinguish a really poor true positive rate from a really nice true positive rate because it's balanced by the false positive rates. So this odds ratio gives you some information of association, but it doesn't tell you if you're classifying the diseased correctly or the non-diseased correctly. It's just a really uninformative total measure of association. Okay. So just to make that point one more time, we have a preference for these measures when assessing performance of a marker: positive predictive values, negative predictive values, area under the curve, simply because the odds ratios don't seem to provide as much predictive power as we think, and they don't distinguish our two types of rates. And a couple other, just to put it in the words of a couple other people in the current literature who've been talking about this, sort of warning us how to present findings. Catan says, please report incremental predictive accuracy rather than a p-value, which means change in positive predictive value, change in negative predictive value. Greenland says report an assessment of incremental risk discrimination, which is what the area under the curve gives you, rather than a p-value. Okay, I think we've driven that point home. Good. So just a few comments. I have 2 more slides for you. We've made it. Keep in mind that some of these tests, when you really want to compare one marker to another in the same subjects, you have correlated data. And this is the most specialized type of data that you need to think about. You need to remember not to treat it as independent observations, and feel free to consult with your friendly neighborhood statistician. I'm around. Another neat observation that keeps coming up in the literature is not to worry if you don't have population-based data in order to compare markers. I thought that was an interesting thing. Even if you can't, Margaret Pepe has this beautiful proof that I thought I'll just tell you about. You can read it. Even if you can't measure positive predictive value because you don't have a prevalence, or you can't measure negative predictive value because you don't have a prevalence, you can compare those measures between markers, even using case control data. So don't let that stop you if you don't have population-based data. And then this slide is just sort of so that you see that I know that there are a lot of things we didn't take into account, that there are many other things you could consider when determining whether a marker works. Timing, right? How early are we able to detect disease with this marker? How does that compare to how quickly other markers are able to detect it? And is early detection even important? And then, the marker accuracy itself might be increasing as you get closer to disease. So that's something that you could condition on. You could look at a screening tool at different stages as disease progresses. The other thing we just briefly mentioned is that we have psychological impact. sometimes of diagnoses, and that needs to be taken into account when picking up optimal cutoff. And then finally, cost effectiveness, which we talked about comparing costs a little bit, but the marker needs to be affordable. So I think that's all I had. Thanks very much for coming to a talk that had statistical in the title.
Questions? Dr. Rainey.
You showed odds ratios for various ROC curves that seem to be independent of the choice of decision value. And yet I have always assumed that odds ratios change with decision values.
Right, right. There are two ways to go about building these regression models. So the odds ratio comes from a logistic regression where the outcome is disease status and the predictor was the marker. The predictor was the value of focus. So the odds ratio is per value of the ELISA value. So for every 1 point increase in the ELISA, that's the increased odds of HSV2 positivity by Western blot. It's the meaning of the odds ratio that's bugging you, right?
Well, it's just, so many tests we do these days, we're not necessarily trying to diagnose a disease, but we're trying to decide what's your chances of having this disease 5 years from now.
Right, right.
And so what's the odds ratio that you'll have a heart attack in 12 months? Or that's a common one.
Mm-hmm. Which you could do with prospective data. It would be the same sort of context. You would look at a marker at a given time, right? And you would project forward and say, of the people who had the marker at this time, how many had that event outcome 12 months from now?
Look at these odds ratios. Your odds ratio is one thing if you're in the first quintile, another thing if you're in the second. If you're in the first quintile, it's 1. You go to the second quintile, it might be 1.2, third quintile, 1.8, fourth quintile, 2.6, and fifth quintile, 5.0.
No, that's your odds. That's not your odds ratio.
Well, no,
that's
it's
your odds
the
of disease.
ratio of odds to the people with the sort of baseline characteristic, which is usually being in the lowest end of the distribution.
Okay, okay. So that's when. So there, you're actually allowing it to pick a different odds for each quintile of the marker value, and I didn't do that. I required the odds to be increasing at the same amount for each change. For each 1 point change. Yeah?
I have a question. We face the problem a lot of times where a paper comes out in a non-lab medicine journal that show you separate two populations, diseased and not diseased, great p-value, and then people say, when are you going to put it online? When are you going to put the test online?
Right.
And then, of course, we run into the same problem you do. It's a lousy test. It's just that it turns out it can separate statistically, and it can separate, but it's not useful because of what you're saying about positive value. Why is there some positive trend we can be optimistic about that people will do what you say and compare predictive values? Present the data that way?
Right.
Because it gives us a false hope that there's a lot of great tests out there when most of those papers never turn into tests. Probably 9 out of 10 never become a test.
I did a quick lit search sort of looking for people to be presenting it in the wrong way, and I found more stuff that was presented accurately. Margaret Pepe is part of this, which I wish I knew more about. There's something called the Early Detection Research Network that's local, and that's one of their messages they're trying to get out. They're writing a lot of editorials and reviews about this topic.
And do you think they're having an impact?
These comments from these papers that I put quotes up from are 2003, 2005. So it is fairly recent that this is being recognized.
I'll just make one comment because I lecture to a lot of family practitioners. I'll give a whole lecture on predictive values and this stuff, and in the end, they'll ask you a question which clearly shows that they think specificity and positive predictive value are exactly the same thing, and sensitivity and negative predictive value. So you've basically wasted. It's a regular feature at the end of that lecture that a few people come up and say, the specificity is 95%, so there's only a 5% chance of false positive. They're not weighing in pretest probability, nothing. So it's just, I feel like is there anybody doing some unbelievably simple way of explaining to these people? Because they're actually in charge of the diagnosis. Like, we're not with the patient. That's why we became pathologists. You know, we didn't want to. But that's what's out there, actually. And so they have this belief that they misinterpret the test a lot.
Is there something new about the way clinicians are being trained? Because all the clinicians I run into are doing the MPH at the same time, it seems like these days, and they're really, really savvy about this.
Okay, any other comments? Because maybe I'm a lone person in the desert. Is anybody think? Go ahead, Mark.
Well, I would just comment that most physicians are not MPH. So I absolutely agree with you. And the area where this comes up routinely, for example, is prenatal risk for Downs, where obstetricians and family practitioners are being asked to interpret a very lengthy report about predictive values. And we can put all the statistics on there, and we do, but all they look at is the result negative or is it screened positive?
Right.
And we know that because somebody's going to make mistakes and one thing shows up or another. They only look at one factor, or we've interviewed them. So it's this idea of there's a threshold, and then that's above it's positive, below it's negative.
And so you have to craft the message carefully, not put too much information, because people are going to look for what's familiar.
Or alternatively, is there a way, that's the other
That's
question,
what we need help
is there a way to present maybe his answer, but present statistical data in our lab reports that you think would be acceptable statistically and meaningful to clinicians? So for example, extending the idea of odds ratio for a result, so kind of what Dr. Rainey's question was, given a result, the higher it is, the greater the odds ratio, the odds relative to a normal population, or perhaps the reverse. What's the possibility that this result is seen in normal individuals? Sometimes that's really the answer. Is this normal, or is this reflecting some disease process?
Right. These predictive
Have you
values.
thought about that, or is there a way we can, instead of giving a result with a single threshold of positivity where we put the asterisk or reported in red, to actually give some probabilistic result?
You know, not being a clinician, I haven't thought about that at all. I think about that sometimes when I receive lab results for me. I wonder, okay, you're saying it's out of range, but you know, how far out of range? Yeah, I mean, I'd be willing to talk more about that.
Mental algebra all the time, but we don't, from the laboratory perspective, we don't help them very much. We just give them the asterisk.
Right.
Do you think we should give them like the predictive, like show them a range of pretest probabilities and then show them the predictive values for each of those? Because one thing I think it's been shown is clinicians can estimate pretest probability of disease in an encounter pretty well. You know, like in an individual encounter, they can put it in a quartile.
Jim's got something to say.
Before you start doing that, there's a basic problem with predictive values. They're great, but one thing you have to know what is the probability of having disease.
You have to
The
get the
pretest
prevalence
probability,
right.
that's what I'm saying.
But
What if you gave
you
them a
don't
range
know
of
that.
pretest probability?
But you don't, so what?
No,
So
because they have, in their mind, they have a
They got-
if a patient comes in and they have, you know, contact with 10 people who have lab documented strep throat and they have a fever, that's high pretest probability. If it's a bunch of cloistered nuns who've had no contact with other human beings, that's low. They can get it into the right quartile, usually, of
You know
pretest
something?
probability.
When you really test them to see what that means in terms of percentages, they can't tell you. I used to do that when I taught the same thing, and I would ask the students, okay, tell me what, the different terms you use, highly likely, definitely, and you'd get these, they would be normally distributed. Percentages, okay? That's the basic problem with predictive value. It's a good idea, it sort of gives you a good feeling, an idea of where you're going, but statistically it really fails because you really don't know the percentage of your population. Unless you actually take statistical, you start studying your own patients. How many are actually diagnosed? How many patients come in my door as a cardiologist that really have angina? And then you can say, okay, the probability if I see angina, and then we do all these other tests to give me a gold standard, that's the problem with it, okay? And it's a guide, but it's not going to get you.
But I mean, isn't the problem in interpretability of the result already introduced by the fact that the normal range was based on a whole bunch of other people, and all you've got is this guy's value, which on this day is this, and I mean, haven't you already?
Worse than that. Normal value is usually based on some artificial population that you select and you run statistics on, and you say, okay, I'm going to make cutoffs. That's the normal range.
Well, you hope it's representative, right?
Right, and it never actually looks at, like an ROC curve does, where it looks at the population. How well can I define healthy from diseased? And it's a fun game to play, but it still comes down to it's a judgment call.
Yeah.
And that's you got to explain to the students. If it's not, it's good. It helps.
Other questions?
John,
Comments? How about
John's got a
comments?
question.
Any comments?
I just have a
John.
comment. that,
Go ahead, John.
you know, I think to some extent you're sort of damned if you do and damned if you don't, because my experience with a lot of genetic tests is when you start to put a probability in the report, you say that your probability of being a carrier with a negative test result is such and such. One of the effects of that, I mean, sometimes we'll just ignore that and say, you know, this it's a negative result, you know, you're off the hook. But the other thing that can happen is then people sort of overemphasize that, and they say, well, okay, you know, my probability is 1%, and you know, and that's different from 1.5, or it's different from 2, and they tend to sort of focus on without recognizing the inherent variability in the underlying data that was used to generate the probability. So I think that's the difficulty, is so often our database that we would use to generate the probabilities in the first place is inadequate, and so therefore that, you know, you get these wide, if you're really honest, you'd have these huge error bars on your estimates.
Right.
And so then eventually it just sort of breaks down, and people say, okay, you know, I don't want to read a one-page analysis, I want an answer. And so I think that's kind of, so I think what it really comes down to is developing better tests in the first place, and that's really where we should be going to the extent that we can.
And I imagine we could get a lot more precision if we were able to take 5 measurements on everybody in order to build the test prediction rule, and 5 measurements on the patient as well, and the average might be the better diagnostic tool.
Well, I want to thank Dr. Magaret for a great talk.
Thanks for coming.